Okay, so welcome everybody to today's Family Medicine Grand Rounds for April 27th. Your activity code is listed here for you for today's session. If you are interested in CME credit, I'm going to go over a few more steps here in the next slide in a moment, but just make sure that you do send that activity code to the toll-free number before midnight tonight. So on the next slide here, I'll go over some information for those who maybe haven't already registered. Is it letting you go to the next slide?
Yes.
There we go. So if you have not yet registered, if you could please make sure you do that. And this is for claiming the CME credit. You would need to send your email address to the toll-free number listed there if you have not already done this for previous sessions. Once you've done that, you just need to text attend and then the code for today, which is listed here. You text that information. You can see in the picture on the right-hand side what that should look like. But if you're having any issues, please feel free to reach out to me, or you can reach out to the CME office as well. But make sure you do that before midnight tonight. Next slide. So as we get started here, I do want to remember to tell everybody to mute your microphone if you have not already done so. Also, if we can remain attentive and engaged in the session. Questions can go in the chat box and we'll be addressing those at the end of the session. And I'll also be putting in the link for our evaluation for our speaker today. So I'll put that in the chat box there as we get towards the end. Next slide. We do want to remind you that we are partnered with the South Central AHEC and our mission statement is listed there for you. Next slide. So for those of you who are going to claim CME credit, you do also need to make sure that you are registered with our CME office. Their website is there, but if you're having any issues, you can reach out to them directly or you can reach out to me, but that is how you will be able to check to make sure that you are receiving the CME credits for these presentations. There's a transcript you can look at, but any questions or information, I'm happy to help, or you can contact the CME office listed there. Next slide. Those who are members of the AAFP, you are welcome to claim credit for this presentation through the AAFP as well. I do think that it was on the flyer, but I should also mention that this presentation does also meet the requirements for opioid training. So I'll just mention that as well. It was approved by the CME office for that. So any questions for AAFP members or any credit questions, the information is there, but always I'm happy to help. Next slide. We also want to make sure that we do cover the nationally established physician core competencies during our presentation. So those are listed there for you. Next slide. And we need to mention that Dr. Mejia has no financial relationships with ineligible companies to disclose. So she's going to present for us. It's Dr. Mejia. I'm sorry, I pronounced that wrong a moment ago, but she's going to be talking to us today about opioid misuse and opioid use disorder in older adults, the screening, management, and challenges. So I'll let her go ahead and get started.
Thank you, Nicole. Good afternoon. My name is Maria Mejia. I'm from Baylor College of Medicine, and I'm board certified on both preventive medicine and public health and addiction medicine. Today, we're going to talk about opioid misuse and opioid use disorder in older adults. There is a national opioid crisis among older adults. However, media coverage and research has focused almost entirely on younger individuals due to their higher prevalence of misuse. For adults 65 and older, opioid-related admissions increased by 34%, while emergency department visits increased by 74% between 2010 and 2015, which is the latest data. Some of this increase is driven by opioid misuse, to which older adults as well younger adults are vulnerable, but some is also driven by the unique challenges of pain management in an aging population. So our objectives today, we're going to describe some of the instruments that we use for opioid use that particularly targeting all the older adult population. We're going to talk about non-stigmatizing approaches for opioid use disorder screening and brief intervention among this group, and also list and apply medications and options for treatment of opioid use disorder. So why is screening among this population important? Well, this group, as I mentioned, the 65-year and older, is forecast to increase to double from 48 million in 2015 to about 88 million by 2050. So the combination of the growing population of older Americans and the increasing rates of opioid-related harms in this group will likely result in even larger increases in the absolute numbers of opioid-related hospitalizations, emergency department visits, and mortality among older adults. We do know that this particular group are more likely than younger adults to be exposed to opiates, as I mentioned before, due to their high incidence of pain, need for acute and chronic pain treatment for conditions such as diabetes neuropathy, large joint OA, fractures, and cancer. However, we're not going to talk about pain management in this lecture. We're just going to address issues related with screening and brief intervention. Older adults may also have accumulated psychological or emotional trauma resulting in anxiety and depression and other mental illness, as well loss of loved ones or other important individuals in their lives, like other caretakers and family members, as well an erosion of what we call social roles, an occurrence of disability. They retire, they have lost their job, or they just know in that competitive market for hiring, so forth. All of which may increase the probability that an older adult uses opiate as a treatment for emotional as well as a treatment for physical pain. All this explains why someone age 65 and above is 3 times more likely to take an opiate compared to someone in their early 20s. Data shows that about 20% of seniors fill a prescription for an opiate in a given year. So that's something that keep in mind when we are managing chronic conditions, including pain management among this group. So this slide is just to show data among this group. Substance use disorders in the older adults have been under-identified for decades, but data shows that opioid-related harms are increasing in this group. The figure shows the estimated opioid use disorder prevalence rate by age and dual eligibility status, Medicaid and Medicare. We can see that younger beneficiaries in the top group experience higher estimated rates than those in the older group, while dual eligible beneficiaries are also experiencing significantly higher estimated prevalence rates of opioid use disorders compared to those with in the Medicare only group. On the right side, the treatment episode data set, which collects data on publicly funded substance use treatment admissions, found that individuals ages 65 to 69 represented only almost 1.2% of the total substance use treatment admissions, a very, very small percentage, meaning that it's a challenge, it's a barrier for treatment access. And among this group, about 1/3, 33%, were opioid-related admissions. So issues that are unique to older adults with substance use in late life. Well, we have the age-related changes, the physiological changes in absorption and metabolism, as well interaction with medical conditions, cognitive impairment, functional impairment, and mental health and substance use related conditions. As well, frequent use of multiple medications for both chronic medical condition as well mental health. As in the social risk factor, we have loss and grief, which are very common in this group. So here just the summary of some of the other psychosocial stressors in aging. The role in the status change, this group retired. Income changes, of course, it decreases once you're no longer in the working force. Physical health decline, cognitive changes, loss in grief, losing your loved one, your partner, your companion, shrinking social networks. Children have left the nest or do not live close to your grandchildren or any other family or loved ones. And of course, loss of independence. It's worth to mention that there is also a rise in opiate misuse among rural elders due to a variety of reasons, including demographics, like rural populations tend to be older than populations in the urban areas. Data shows that 16% of rural Americans aged 65 and older, data shows that about the rural population, 65 and older, are about 16%. There's also a higher proportion of those that are 85 and older who are more likely to have chronic diseases and disabilities. Rural populations also show a lower income, higher rates of unemployment, substandard housing, and all these social demographics. As well, we know that health literacy is a big issue when it comes to opioid misuse. Okay, some of the potential challenges for the screening, where we have, of course, some physician factors among providers, some stereotypes that we might have about addiction, stereotypes about older adults, as well lack of knowledge about treatment and how to approach this high-risk population. We do have patient factors such as denial, as well as shame and guilt. This is something that we don't talk about it. And of course, there are some diagnostic factors. Comorbid conditions make up score or be used to explain symptoms of substance use and misuse. In this particular group, the DSM criteria are sometimes less applicable. It's hard sometimes to discern between symptoms of tolerance or withdrawal or intoxication, separate different from side effects from other medications that patients might be taking, or symptoms related to other chronic conditions. So here is just the screening workflow recommended by the TIP expert panel from SAMHSA. They do recommend universal opioid use disorder screening. Every person over the age of 60 should be screened for alcohol and prescription drug abuse as part of the regular physical examination, at least once a year. We recommend the brown bag approach, which is a common practice that encourages patients to bring all the medications and supplements to their medical appointments. So we have a chance to go in detail about what medications the patient is taking, for any potential interactions, and just some changes on the disease management. This provides clinical staff with an opportunity to review and to discuss the medication that the patient is taking. A screen or rescreen if certain physical symptoms are present, or if any major life events like a traffic accident or a car accident or any ADL issues, or if there are any major life transitions like females menopause, retirement, maybe a loss of caretaker, changes on a caretaker, so patient has moved to a different living arrangement, or empty nest. Each practice should have a plan in place for patients who screen positive in terms of what's the next step in terms of care management and referrals. So if someone has screen positive for a substance misuse, assess which substances, and as well any other comorbidities, including mental health and psychiatric conditions. If this patient qualifies for as a substance misuse, brief counseling, as well monitoring and follow-up, regular follow-up. This patient might need more frequent follow-up. If the misuse continues, try to negotiate a plan or refer the patient to treatment if you don't have the resources in your clinic to help the patient in the recovery path. If the patient has a substance use disorder, brief counseling and treatment referral are recommended. Consider medication, either provided by you in your practice or refer to another provider. And of course, ongoing assessment and support. Here, working with other providers, if you are not the one managing the substance use disorder, are highly recommended, particularly when patients have multiple payers, multiple providers. Don't forget that to check the prescription monitoring system just to make sure that there's no duplication. Is a mandate in Texas since 2 years ago, so just keep an eye on that. Okay, there are different approaches to brief screening for drugs used in primary care settings. These are the most widely used. We have the single item drug screening. It's a simple question: how many times in the past year you used an illegal drug, recreational drug, or a prescription medication for non-medical reasons? Sometimes you have to go the extra mile of what that means, non-medical reasons. If, for example, if we prescribe opiates for a knee injury 3 months ago, but the patient don't have the symptoms anymore, but keeps taking it just because he feels like it's more energy or anything like that. So patient might think that it was prescribed by his doctor. The patient is taking it for a medical reason. So just kind of go sometimes into those details, give you a better picture of what is going on with these patients. A second approach is a 2-item drug use disorder screening. Has the first question: how many days in the past year have you used drug others than alcohol? Positive is when we screen 7 or more days, and if it's fewer than 7, you can go to the second question: how many days in the past 12 months have you used drugs more than you mean to? So it goes back to what I was asking about. I was mentioning about getting additional information about the use and misuse. Some of these questions, some primary care practice have already embedded these questions in the electronic medical system, or sometimes they are part of the intake while the patient is updating the demographics or any intake questions that you might have in your practice. It's important that you're not the one asking these questions. If you have someone else like the MA who goes through this, so provide some level of education in terms of how to ask the questions in non-stigmatizing way. So education for all health providers, MAs, front desk. Sometimes the questionnaires are handled by the clerical person in the admissions. So just make sure that everybody is aware of the importance of, answering questions that the patient might have, or approaching the patients in a proper manner for them to feel comfortable to disclose this type of information. Here are other screening tools based again on clinic practice and systems preference. We have the tobacco alcohol prescription medications. The TAPS tool is a 12-step screening and brief assessment. It has been developed and tested in primary care settings. It's based on a NIDA quick screen approach. It also detects, we like it because it detects substance use disorders only for the most often used one in this particular patient population. We also have the alcohol, smoking, and substance involvement screening test, so-called ASSIST. It has is a computerized version. It has 26 questions. It's lengthy, but it's in detail. There is also a shorter version that makes the use more efficient. So here again, is the ASSIST, the short version. Then we have another one that is called the opioid tool, particularly for those who work on pain management with these populations. It's a brief self-report. It's used in primary care settings because it assesses risks for opioid abuse among chronic pain patients, but is non-specific. Then we will have others like the SOAP, has 24 items. It's again lengthy, it's broad screen, and is less specific for this patient population. So the important thing of the screening, regardless what tool you're using, is to determine the extent of the assessment, which it depends of the screening results, the way that you engage with your patient, the type of information that you obtain. The extent of the assessment depends on a provider's ability to treat the patients directly. If you want to do a brief assessment, just make sure that the patient tests positive. What is the next step? Are you equipped to provide a more detailed assessment on a screening tool, or you should refer the patient to a different provider to do a more in-depth assessment, such as a behavioral health provider or any other provider that has ability to manage this type of patients or provide a medication management. If the provider does not offer the medication for opioid use disorders, the focus should be just on the medical assessment, making sure there are no any side effects, that the patient is not a risk, also making a diagnosis of opioid use disorder, and most importantly, patient safety. This allows the provider to refer the patients to the appropriate level of treatment. Okay, let's go to the patient evaluation. Well, addiction is a brain condition that requires competent and compassionate treatment. The language of recovery includes patient-centered terms. For example, person with opioid use disorder, patient with alcohol use disorder, with tobacco use disorder, and so forth. Same way that we talk about patients with diabetes, patient with chronic pain. It's important to ask direct questions about concerns. You can preface the question with a link to a medical condition of health concerns to make the patient feel more comfortable to disclose this type of information. When approaching the patients, the use of a supportive, no confrontational approach is recommended compared to a more assertive style. We sometimes, as physicians, we have this way to talk to our patients, a very assertive way, but might not be the best approach, particularly when we are addressing concerns about related to substance use and misuse. show genuine interest in the overall health and well-being of your patients. You building this type of therapeutic alliance is very, very important when managing this type of issues in clinical care. Discuss substance use in the context of an overall assessment with the goal of health promotion. So the patient as a whole, you're treating the patient as a whole, you're not treating just the opioid use disorder or misuse, right? Also show some understanding of their health behavior. Be helpful to note goals in the patient worlds. Decreasing, my patient might not be ready to discontinue or quit taking certain substances like opiates or quit smoking, but just meet the patients where they are at in their journey to stop using or misusing substances. Similar to other medical clinical interactions involved in taking care of the patients. For example, if you have a patient with diabetes, you might need to taper, either increase when the diet is not working, so you might have to add metformin, or any other insulin. So just talk to patient that, okay, this is where we are. We're going to start with this, and then we're going to progress, or we're going to adjust according to where you are at in terms of recovering or stopping the use or misuse of any of opiates or other substances. Okay. The substance use history patterns. When you're taking your history, this list outlines the components of a comprehensive medical assessment. However, providers and clinics may have their own policies, their own protocols and preferences when it comes to evaluation and documentation. When addressing substance use history, ask gently and respectfully questions related to the quantity, the frequency of the use, medications, and illicit or recreational drugs, with the assumption that this is information. With the assumption that this information is important, whether the patient's use is a problem or not. You just want to understand patient's concerns and where is the current situation of the patient. You should focus on facts rather than questioning the patient's judgment. Oh, why are you taking this? Why did you forget to take the medication today? Or why did you double the dose if you forgot to take the medication yesterday? You didn't take it yesterday, it's because you don't need it. So perhaps we need to discontinue. So that kind of approach might be very judgmental, instead of understanding what were the issues or the scenarios that became a barrier for the patient to be adhering to the taking the medications as indicated or as prescribed. At the bottom of the slide, we have the high burden equal greater risk for falls and cognitive decline. So when we review on medications, not only substances, illicit and recreational, I'm sure you are familiar with the New Beers criteria from the American Geriatric Society, which is a measure of for CNAs active polypharmacy, like including opiates, antidepressants, antipsychotics, benzos, and which one? In Z drugs. So we know that benzos plus opiates are the #1 pharmaceutical combo for overdose days. Very, very concerning in the older population. Just to keep that in mind. So this slide shows a categorization of substance use among older adults. It is a good summary. This was published in 2014 by Curvis. It's a good summary for this group of patients where abstinence is when no drinking or no use of illicit drugs at all. We consider low risk use when it comes to alcohol when they drink within the safety guidelines, 7 standard drinks per week, and no more than 2 drinks for any occasion. and only appropriate prescribed use of prescription or over-the-counter medications. And they're no guidelines for low risk for illicit drugs. So any use of illicit drugs in this patient population is considered a risk or high risk. At-risk use when they are drinking beyond the safety guidelines, or intentional off-label use of prescription or over-the-counter medications, like taking the medication even once in a while that is not prescribed as directly for that person. And of course, any use of illicit substances. Problem use, substance use that results in social, medical, or psychological consequences, regardless of the quantity or frequency of substance use. So mimicking some of the DSM-5 criteria. Problem user may or may not meet the criteria for substance use disorder. Here are the DSM-5 criteria. There are 11 criteria. So a substance use disorder is defined as having 2 or more of these symptoms in the past year, just different from the prior criteria. A tolerance and withdrawal alone don't necessarily imply a disorder. And the severity is related by the number of symptoms. 2 or 3 was considered mild, 4 to 5 moderate, and 6 or more are considered severe. I wanted to show this slide by Lehman and colleagues from 2018. The use of the DSM-5 criteria for the diagnosis of SUDs in older adults can be challenging, since older adults often metabolize or process opiates differently. When we age, our bodies have more fat. This raises the level of an opiate in the bloodstream. When you get older, your kidneys may not filter the drug out as efficiently, causing it to linger longer in your body. What's more, opiates can interact with other drugs that older people take, such as medicine for sleeping, seizures, and nerve pain. This is why this group, this patient population, are more likely to have side effects compared to someone in their 20s or in their 30s. In fact, one study showed that nearly 30% of men 65 and older had a reaction from taking an opiate, which is much, much more lower in the younger population. Right. So some of the big difference from the DSM-5 criteria, the substance taking greater amount than intended, again, because of physiological changes. An older patient might be impaired just by using the same or the less amount of the medication, either because they start another medication recently for another medical condition. There is persistent desire or successful effort to cut down, where other patient may not realize it's problematic, especially when there is taking it for a long time for, like, let's say, chronic pain or anxiety. Or there is no one, the patient is by itself, or by him or herself, and there is no one to witness those changes. Repeated use that leads to inability to perform, that's the criteria. Well, in this patient population, the role impairment is less pertinent, since the patient might be retired and again might be living alone. The criteria of value, social or work-related roles are stopped because of use. Well, again, because in this patient population, since the living arrangement, they are retired, it can be less obvious. Since there is no one to observe or the patient are no longer working. Substance use disturbed by medical or psychiatric complication. It's about the same. However, the medical consequences of the substance use or misuse can be serious, including confusion, falls with injury, and psychiatric conditions. one of the things is that about talking about dangerous situations, particularly in states like here or let's say Florida, where an older population, there many of them still are driving. So use or misuse can be a high risk for driving, for impaired driving. So that's something to consider when these patients have been taken for a while, benzos or opiates for chronic conditions of mental health. The tolerance, well, symptomatic impairment may occur without an obvious need for increasing the amount, again, because of physiological changes in this when we get older. And withdrawal syndrome can occur even with more subtle symptoms such as confusion. So it's the confusion because the underlying dementia or any cognitive disorder, or because the patient is taking a medication, another medication that can have these side effects. So there are different things to take into consideration when we assessing an older patient. Here is just a sign of possible problematic substance use in older adults. So in general, psychiatric symptoms, it can be subtle, but when patient complains of recent sleep disturbances, even when you have been managing their these patients for a long time, or the caretaker reports frequent mood swings, or even the patient, him or herself. Anxiety, depression, this can be a little challenging. Is it a new situation with the living arrangement? Is it because it's a side effect of other medication that they're taking? Physical symptoms, nausea, vomiting, poor coordination, and tremors are the most frequent ones when it comes with substance use. Physical signs like unexplained injuries, falls, bruises, malnutrition, cognitive changes, and of course, social and behavioral changes. Harder to observe, but that is what is so important to talk to the caretakers and family members when addressing new concerns with our older patients. All right, let's go to physical examination. This list outlines the components of a comprehensive physical exam for patients with OUDs, with opioid use disorders. But again, providers and clinics have their own protocols in terms of evaluation and documentation. The findings, the importance of this, the physical examination, is that the findings may point to medical complications requiring further evaluation and treatment. For example, a murmur for endocarditis for those who are intravenous drug users, or evidence of abscess or cellulitis. And of course, other symptoms like GI, gastrointestinal, hepatomegalia, hernias, then it should be addressed. Are they related to chronic alcohol use or any other substances? Lab testing, again, it varies according to practice guidelines. However, the baseline labs for, of course, for women of childbearing age, pregnancy test is very, very important. It might not be as relevant for an older population. And the urine drug screen, those are standard. Additional ones, recommended labs depending on patient needs, tailored to the patient's conditions. The complete CBC, blood counts, electrolytes, hepatitis C and A, and of course HIV, and liver function tests. Okay, because it's brief intervention is very important as part of our counseling inpatient education. We are in the business of helping our patients to facilitate change, right? This is the very evidence-based, widely used trans-theoretical model, first described in the 80s by Prochaska for those who are interested in behavioral health. It recognizes the change as a non-linear process involving several stages leading to successful behavior change. In other words, you meet your patients where they are at in terms of recovery, the journey, or their intentions and motivations to address substance use disorders. You have some patients that can be in the pre-contemplation stage. They have no intention to change, or they just know, they are just unaware of there is a problem or the possibility of successful change. We see that suddenly some of our patients have increasing the amount of opiate use because they feel that the current dose is not helping, or they start mixing that with cannabis or CBD components that they now, widely use, particularly in this group. You can be in the contemplation stage. You are aware of the problem. Yes, I know I'm taking this medication or this drug more than often than it was prescribed. I'm running out of the prescription early, so I have to go to my second doctor to get a refill, for example. They're aware, they're considering change. They come and ask you how you can help them. But there's still no commitment into action. Let's say if someone has increased their frequencies because they're afraid of that. If they decrease the amount of use, the pain might increase, or anxiety might go up, or they just won't be able to sleep, for example. Preparation. Well, this is the patient that has a clear intent to change, and it starts making a small behavioral modifications toward change. But how the patients understand someone with chronic pain that health provider, or have also talked to his therapists about other techniques to manage pain and decrease anxiety, like breathing exercises and mindfulness. There are those who are taking action, right? They're taking a decisive action to change. These might be the one, okay, doc, I'm ready to stop all these opiates. I want to start a medication that can help me to stop taking the opiates or the drugs, illegal or illegal. I need your help. So these are the patients that might be indicated for opiate management with Suboxone, with medication-assisted treatment like Suboxone and so forth. Very important is the maintenance phase. So this is the one where we are working to prevent the relapse and consolidate gains. So when someone has a substance use or substance misuse, is always at risk of relapsing. So what can we do to help this patient to be ready to prepare for the potential risk of relapse, the triggers, how to cope with, how to build coping skills to be able to deal with triggers. Patients just, you can put them in a bubble to eliminate all triggers that they might be exposed to. This is just to show that the first two are no firm commitment to change, while the other three stages are a firm or firmer commitment to change. So the brief intervention is goal by stage. Brief interventions can be most effective when the goals of the interventions are tailored to the patient's current state of change. So we talk about, this is what we call motivational interviewing. It's a collaborative conversation style for strengthening a person's own motivation and commitment to change. It's widely used. We do a lot of training and provided education on MI because it has proven to be effective when it comes to behavioral change. For the relapse pre-contemplation and the contemplation, the goal is to build commitment to change. You know, for those who have relapsed, and for those who are not ready to change, so how can we move the patient from stage 1 to stage 10? So how can we help a patient to kind of move forward? For those who are in preparation or are ready to take action on the maintenance phase, the goal is to make a plan for that change, something well established of how we are going to accomplish their goals. So patients screening positive for substance use are likely to be in the contemplation, and they haven't yet considered the substance use to be a problem or have been thinking about, but they have not yet decided on following through with making those, making the necessary changes. All right, let's go to this question. Your next patient is 63 and new to your practice, is coming for back pain. They work as a landscaper and have been taking opiates as a prescribed by their primary PCP for the last 10 years. The previous doctor recently retired under substance, so he comes to you as a new patient under substance use screen today, screens positive for prescription opioid misuse, having resorted to buy hydrocodone pills of a coworker whose mother recently passed from cancer and taken more than previously prescribed doses. You share the patient's screening results with them while discussing their medical history and ask the patient their thoughts on their opioid use, trying to assess where the patient is at. The patient states, I don't see there is any problem except my old doctor retired. The patient states, but now that you are my new doc and that you should fix that problem. The patient's current state of change with regards to the opioid use is most likely. All right, let's see who says something in the chat box. Is the patient in the pre-contemplation, contemplation, preparation, or action stage? No one? All right. The patient is in the pre-contemplation stage. Apparently, the patient has no intention to change and is unaware that was a problem. It was normal. I've been taking it for so many years. Hasn't got in trouble. So patient is not conscious about this being an issue. All right. Okay, just to go to what are the medications that are FDA approved for treatment of opioid use disorder. So we have three types of medications. Medication-assisted treatment is recognized as the gold standard for treating opioid use disorders, as 4 out of 5 people with opioid use disorder will chronically relapse when treated with non-medication therapies alone, meaning just behavioral therapy. It has shown that is not as effective as treating in a combination of behavioral and medication or pharmacotherapy. So medication has shown efficacy with and without behavioral counseling. Patients who are medically and mentally stable can benefit from receiving opioid use disorders medications in integrated care settings. We strongly urge physicians, nurse practitioners, and physician's assistants to obtain waivers that will qualify them to offer buprenorphine pharmacotherapy as a means to provide medication-assisted treatment. So we have 3 types of medications. We have the agonist, the partial agonist, and the antagonist. In the agonist, fully activate the opioid receptors. We have the methadone. This is required to be in a special setting, the so-called methadone clinics. They need a special authorizations, training, and so forth. These are the patients where the patients go every day to get those. Okay, it's very strong. It's good. Is the one that has the longest data. It reduces opioid cravings and withdrawal and blunts or blocks the effects of opiates. Then we have the partial ones, the buprenorphine, Suboxone, Suboxone, Sublocade. It activates the receptor but produces a diminished response even with full occupancy. It suppresses and reduces cravings for opioids. Suboxone is a single buprenorphine presentation, while Suboxone is a combination of buprenorphine and naloxone. The idea is to prevent the risk of diversion. And then we have the antagonist. The naltrexone blocks the euphoric and sedative effects of opiates and prevents the feelings of euphoria. Here is just to go, to show you the recommended daily and maintenance doses. It's not for the purpose of, memorize all of them, but for you to be aware of there are different medications in the market, and also to just give you an idea of the cost difference between them, particularly for those groups, patients who don't have insurance or are underinsured. Most of the insurances, Medicaid and Medicare, do cover most of these medications, the generic ones, but co-pays, co-insurance is still an issue. So here is a long question. Let's see what slide we are. This is a 64 years old patient who comes to your office for renewal of their pain medication, has recently relocated to the area. She's been taking the medication because it helped with the back pain, but every time that she has tried to take it off, her back pain returns along with pain in other joints. Over the last 4 years, she has gone from 1 to 2 to now taking 8 to 10 daily. She can barely get out of the bed. If she doesn't have her medication, but I find herself nodding out midday, which scares her, and she's home alone with her granddaughter or grandson. She really liked to get off the opiate, especially since the causing overdose on pain pills last year, but she has resigned herself that her body is too sick without them. So what would be the gold standard treatment for this patient? What we would recommend to this patient? We recommend a detoxification or medical withdrawal management and 30 days of residential treatment, or an detox plus 90 days of residential treatment, medication-assisted therapy, which she can take at home, or just recommended to behavioral group therapy like Narcotic Anonymous. Anyone? No one?
Sí.
Sí, yes. Very good. Yes. The idea is that we assess the patient as a whole and identify if the patient can have treatment at home without also a support network. So she seems to be the right candidate for MAD. Okay. So what are the advantages and disadvantages of treating MAD with MAD in primary care office-based setting? Well, the advantages, of course, is less stigmatizing. There was so-called methadone clinics. Patients go there every morning. They had to miss work. While with MAD, you can prescribe the medication and the patient can take it on a daily basis as any other medication for a chronic medical condition. However, the disadvantages is that some of these patients might not be ready for it, because they have the housing instability, they don't have family members, or they're probably not in the right stage of change and ready to go through this process. The advantages is recognize that it reinforces that opioid use disorder is a chronic disease. Again, treating as any other chronic and medical conditions. But because they go to your office on regular basis, it does not provide patients with a sober, safe, supported recovery. So you cannot ensure what goes on at their home or their daily environment. It does out of your control. But for that, you can refer the patient to other supportive services. In many areas, OUD treatment is not available. We know that rural areas are having a lot of issues. However, telemedicine has been, improving access to medication-assisted therapy. And the main thing is that partial agonist therapy like Suboxone, like buprenorphine, may not provide sufficient opioid receptor activation, meaning that might not be strong or good enough for certain patients with severe disease. So there's some patients that might be better off in methadone clinic, but might not have access to it. Primary care clinicians who treat patients for chronic pain have an effective modality for addressing OUD that can be inadvertently resolved from chronic pain management. Okay. However, the disadvantage is that patients wanting non-agonist medications treatment, like naltrexone, will need opiate withdrawal management and to tolerate 7 to 10 days washout period. So many of those patients relapse or just decline management because the withdrawal symptoms are too severe. Okay, let's pass this question so we can finish. Deciding if a patient is a good candidate for office-based for overtreatment. Well, so these are the main questions that we should ask if we're able. Can the patient adhere with the treatment requirement, meaning that the patient has the transportation needs or means to go to the clinic on a regular basis? Can the patient go and have the labs? Can they go to the appointment? Can they take the medication as prescribed? Are any other medical or psychiatric conditions too unstable that prohibit the patients to engage on ABOT? Any other psychosocial circumstances of the patient that's stable and supported? If the patient lives with someone, lives alone, if you have concern for the safety of the medication, the grandson, the roommate might steal or might divert any risk of diversion and so forth. Same here, if the patient is taking other medications or misusing other substances that might interact with the OBOT, you know, such patient medications for chronic pain. So finally, I just want to mention that there are some changes in the buprenorphine prescribing changes. You don't have to do the training for 30 patients. However, you still need to require to fill the X-waiver requirement to be able to prescribe. So you need to submit that through SANSA and to get your DEA adjusted to be able. So for up to 30 patients at the same time, you just need to submit it. If you want to increase the panel to 100 or to 275, then you will need to complete training in some of the minor requirements. But we do strongly encourage all of us that in primary care, regardless of what as our population is focused, to get the waiver. Just to finalize some summary of the main points. We know that substance use disorder in all the groups can be, the identification and the screening can be difficult in older adults because overlapping symptoms with medical disorders that are common in older age. There are some screening tools. You can use any of the ones that are embedded in the medical record, or you can choose one that are of your preference. They're all relatively good. Just as mentioned, include a respectful and non-stigmatizing approach, along with the questions. Medication-assisted treatment is the gold standard for treating opioid use disorder in adults. Methadone is a full agonist, then we have the buprenorphine, the partial agonist, and the naltrexone, which is an antagonist. These are the references. And lastly, I just want to leave you with this course that we are offering. And we have 2 minutes for questions.
Do we have anybody with any questions? Please feel free to either put in the chat box or you can unmute and either have a question or a comment if you'd like.
Thank you very much for the great talk.
All righty, thank you very much. Have a great day. And I go get the waiver. Thank you.
Thank you so much.
You're welcome.
Thank you, Dr. Mejia, and thank you everybody for joining us. If you could also follow the link in the chat there to provide feedback for her, we'll get that information to her. But thank you so much, everybody, and hope everyone has a great day.
Thank you. Bye.